Thanks very much, Antonia, for your kind introduction. I was going to answer Danilo's first question, where the greatest number of participants to this workshop come from. I knew it was United Kingdom, although I didn't calculate the numbers, but it has to be United Kingdom. Why? Because we're fed up of Brexit and want to come back to Europe. That's what that's about. Okay. My task this morning actually is to discuss the challenges associated with fetal monitoring, but put it in the context of the clinical arena. And that is because a lot of the problems we have in terms of perinatal outcomes actually relate to not necessarily what's going on with the fetal heart rate, not necessarily what's going on with hypoxic ischemic insults, but a whole range of other intrapartum stressors that are quite often not amenable to fetal heart rate monitoring, but contribute quite substantially to adverse perinatal outcome. But if I asked the very basic question, why do we monitor babies? Why do we even bother? What's the essence of fetal monitoring? And I will suggest that the aim of fetal monitoring in current clinical practice is to be able to predict significant intrapartum asphyxia. Asphyxia here is defined as the accumulation of metabolic acid on the fetal side of the placenta. In other words, the exit of metabolites and transfer of waste products has become so impaired that the fetus is beginning to accumulate metabolic acid. That's asphyxia. All babies that go through labor will be asphyxiated to some point or the other. The key question here is, when does it become significant? When does it pose a danger of injury to the baby? So when we monitor babies, that is the basic question we're asking, to detect significant intrapartum asphyxia and do something about it before the baby becomes injured. And also to be able to do all of that without unnecessarily operating on babies and mothers that don't need those operations. Because those procedures are not risk-free and they're not cost-free either. And they perpetuate our tendency to do things not just randomly but in a very defensive manner. And the reason I started from that point is exactly because hypoxia is not the only cause of fetal damage. In fact, numerically, the contribution of hypoxia to motor deficits and cerebral palsies in the long term actually is in the minority. You have a whole list of other adverse events that occur during labor. So that should be my third bullet point, which contribute to damage, but which we have little or no access in terms of how best to monitor it. So if you look at the bottom, if I invite you to look at the bottom here, so this is fetal systemic inflammatory response syndrome, intrapartum pyrexia, prolonged preterm rupture of membranes, histologic choreamnionitis, phenicitis, the signature of fetal host response, fetal strokes, chromosomal abnormalities. Collectively, these things contribute far more to adverse motor outcomes in these babies. And we have no mechanism for monitoring these processes in a reproducible and consistent manner. I've given you a short list of some of the intrapartum stressors that I'm talking about. So things like Meconium stained amniotic fluid, things like maternal fever, clinical choreamnionitis, use of oxytocic agents, the fetus that is in the preterm period or in the post-term period, the diabetic fetus, the fetus that hasn't grown or developed properly in the womb. And sometimes you have varying combinations of these adverse factors. We have to accept and acknowledge that there are no known consistent reproducible fetal heart rate patterns for these conditions. There's just no good way of monitoring them. You just do not know what you expect. And these conditions just don't exert adverse effects on the fetus, but also make those fetuses more vulnerable to additional insults. So we have to consider that despite the fact that we're in the 21st century, the rates of hypoxic ischemic encephalopathy, cerebral palsy, neonatal deaths have remained static ever since we started collecting the records back in, say, about 50, 60 years ago. And our interventions are escalating. It doesn't matter which community you look at. Operative interventions have escalated. Inductions of labor have more than quadrupled. Yet, we're not making the impact that we're hoping to make. And that may be related to the fact that current tools for fetal monitoring seem to focus more on hypoxic ischemic insults and overlooking these other non-hypoxia, non-ischemic pathways, particularly inflammatory pathways, maybe even traumatic pathways of exerting fetal injury. Do we even know whether these pathways are amenable to monitoring? And if there are, how do we access those pathways? So one of the challenges for this community, given the expertise we have, not just amongst data scientists, computer scientists, mathematicians, and clinicians, whether this community has it within themselves and the resilience and resource required to be able to mitigate and deal with this challenge. Those conditions that I have listed do have a common pathway. And what is that common pathway? The entire fetal programming for defense during labor is geared towards protection of mean arterial pressure. So as long as the baby is able to maintain his or her fetal mean arterial pressure, the risk of injury is minimal. If on the other hand you have processes, particularly the list I've just given to you, that interfere with that adaptation such that the mean arterial pressure begins to fall, you can see that the risk of damage, including death, also begin to increase. So if you asked me as a clinician, what would be the most important biomarker for protecting babies and detecting the risk of injury? It's probably fetal blood pressure. But that's the one thing we don't have access to. So we use proxies that are less sensitive and less specific, and we're paying the price for it. This is work from Jeff Phelan, American obstetrician, that showed that even amongst brain-damaged babies kept in a registry, if you looked back to their CTGs when they were admitted in labor, over half of them presented with normal-looking CTG. And in that proportion, nearly 10%, the CTG remains completely normal throughout labor. But these are brain-damaged babies, raising the question, actually, that even at the time that they're coming onto our labor ward, there's a proportion of those babies that are already in trouble. We don't know that. And inadvertently, we may be adding to their problems by allowing them to labor and exposing them to intrapartum harm. I'd like to talk about maternal fever because maternal fever is very common in most developed healthcare systems where epidural is used. Maternal fever is, very, very common. And most of those maternal fever have little or nothing to do with infection. But that's not the point. The point is, when the mom is hot, the baby is hotter. The baby's core temperature goes up. And heat is very bad news for the developing brain. And one of the things that maternal fever does is to totally obliterate the fetal-maternal temperature gradient. And of course, once fetal temperature goes up, then the fetal metabolic rate also goes up. An increase in metabolic rate requires an increased delivery of resources, increased delivery of oxygen to sustain that increased metabolic rate. Now, if you're unable to deliver that, then that tissue becomes at risk of hypoxic damage. We know for sure that babies that are born to women that run temperature during labor have an excess risk of neonatal seizures, and that's regardless of how the temperature came about in the first place. That's beautifully illustrated in this American study. If you looked at the risk of hypotonia lasting longer than 15 minutes, assisted ventilation, low APGAR scores both at 1 minute and at 5 minutes, or the risk of seizures, as the temperature increases, those risks also increase. So there is a dose-dependent effect when it comes to temperature. It is not only the fetus that pays the price of an increase in maternal temperature. This chart here, taken from the study by Zackler, shows that if mom runs temperature, by 2 hours following the increase in temperature, myometrial activity degrades quite significantly. And a reduction in myometrial activity attracts the obstetrician to put up oxytocin. In a woman that's potentially hot, baby hotter, now we're introducing other adverse things that might exacerbate the risk that the baby is at. What about chorioamnionitis? Now, chorioamnionitis is an endothelial disease. So any structure within the fetal body that is supplied by blood and therefore blood vessels and therefore endothelium runs a risk of activation during chorioamnionitis. And what does this mean? It just means that all of these organs suffer from the effect of host response to that infection. So these babies, as you will know, quite often will need inotropes to support their cardiac function when they're in the neonatal unit. There's neuroinflammation. They're at risk of necrotizing enterocolitis. There's renal dysfunction. Quite often they have DIC. So babies that are operating in this arena don't only have direct damage to their neural networks because of the inflammatory mediators, but it predisposes them to additional damage because of exposure to some of the things that we do during labor. And it does that because inflammation sensitizes the neurologic tissue to hypoxic damage by lowering the threshold at which hypoxia exerts apoptosis of neurologic tissue. And you end up with a magnitude of injury that is over and above what you would expect if hypoxia was operating alone or if inflammation was operating alone. That's again beautifully illustrated in this study from Saskia Eklund, who took a group of baby rats, infected half of them with lipopolysaccharide and exposed them to hypoxia ischemia over that time frame. And the other half just gave them normal saline and measured the size of brain damage. And what you can see here is exposure to hypoxia ischemia will cause far more damage in the group that was infected compared to the group that wasn't. Now, part of the problem we have in clinical practice is more than 90% of women who have babies that are affected by this process show you no markers at all. Their temperatures will be normal, their heart rate will be normal. And that is because of the disconnect between the intrauterine fetal compartment and the maternal systemic circulation. So even if you look at epidemiological studies in humans, it makes exactly the same point, that if you have hypoxia alone, the risk of neurologic damage is relatively small. If you have inflammation and hypoxia, the risk increases by almost 80-fold. So this is not just something you can demonstrate experimentally. Epidemiological studies in human arena also makes exactly the same point. Because we're so targeted at looking at hypoxic ischemic insults and using pH as a marker for fetal injury or risk of fetal injury, when you have infection, there is no significant difference in babies that are infected and the ones that are not infected regarding their acid-base status, wherever you set the threshold for pH. So using acid-base status to risk profile babies that are infected can be positively misleading because they're at risk of injury from inflammatory pathways and synergistic pathways, but their pH normally will not look different from the ones that don't have infection. Whereas if you ask a better question, what is the neonatal adaptation like? Suddenly you begin to see that infected babies will have significantly lower APGAR scores both at 1 minute and at 5 minutes, suggesting that although your acid-base status is protected, which is what the clinician is busy looking out for, the baby's neonatal adaptation and performance is actually significantly affected. Another thing I'd like to draw your attention to, over the last 10-15 years, we've become very good at using magnesium sulfate infusion to mitigate the risk of cerebral palsy in the long term. Now, this is data coming out quite very recently that actually the neuroprotection from magnesium sulfate wanes in women that have chorioamnionitis. So if you can demonstrate or have a strong suspicion that a baby is in preterm labor because of chorioamnionitis, the idea that you're waiting around to give magnesium sulfate to protect the baby is not helpful, because in that subset of babies, neuroprotection is not affected. Whereas the ones that do not have chorioamnionitis, there is neuroprotection from exposure to magnesium sulfate. And that doesn't change whether you're talking about cerebral palsy or moderate cerebral palsy. What about meconium? Another common clinical setting. Now, the one thing we don't often focus on is that meconium exerts some adverse effects on fetal placental circulation, particularly vasospastic effect. But also, if it's sufficiently concentrated, it can cause necrosis, ulceration, and thrombosis in those vessels. So even if a baby passed meconium as a physiological process of maturity, the presence of meconium in the intrauterine compartment has the capability to embarrass the fetal placental circulation to the point where the baby then starts to become hypoxic. And the other thing meconium does is to impair the ability of the amniotic fluid to continue to maintain its antibacterial activity. So if you were to select a panel of adverse perinatal outcomes, you can see that the risk of those adverse outcomes in babies that are operating within meconium-stained amniotic fluid compared to the ones without meconium-stained amniotic fluid is significantly different. Babies that haven't grown well during pregnancy, have a long list of adverse metabolic and endocrine adjustments. And those adjustments make their performance and their behavior during labor different from babies that are appropriately grown. They tend to do the same things qualitatively, but quantitatively they tend to do it in less time because of the reduced resources that they have. They also have cardiovascular disturbances, which makes monitoring them a bit more tricky because they start from a lower base in terms of susceptibility to hypoxia. They run higher heart rates so that the room for maneuver is less. Their blood pressure is lower so that when it comes to compensation, the room for maneuver is also small. Their glucose utilization is also poorer. On the opposite side of that spectrum would be the diabetic fetus. Now, the diabetic fetus, the primary problem is fetal hyperinsulinism. And fetal hyperinsulinism, in other words, excess production of insulin because of exposure to high maternal glucose load, is what causes this adverse metabolic consequences. And it's not just the fetus that bears the burden of excess insulin production. The placenta also does. So these babies will develop a specific type of placental vasculopathy that affects the placenta in such a way that when there is risk of oxygen delivery, those placentas do not perform quite well. Why? Because the diffusion distance from the blood vessels within the villi and the intervillar space where there's oxygen and nutrients is too large, so that if the baby needs oxygen delivered quickly or glucose delivered quickly or resources delivered quickly, it cannot match it because the diffusion distance is so expanded. And this makes the point why even when you manage diabetes, as far as we understand it, using maternal glucose parameters perfectly, those women, their babies are still at 2 to 5-fold increase in risk of stillbirth and adverse outcomes. It's beginning to emerge, actually, that diabetic babies display a particular type of fetal heart rate abnormalities. This hypervariability pattern, this is work done by Timonen. If you select a risk of hypoxic markers, they seem to be more expressed in women or babies born to women that have gestational diabetes compared to the ones that don't have gestational diabetes. So when it comes to fetal monitoring, how do we approach the subject? We approach the subject by making a clear distinction between a normal CTG or a normal fetal heart rate pattern and a non-normal or an abnormal fetal heart rate pattern. If you can demonstrate that your baby has, early in labor, a normal fetal heart rate pattern, defined as exhibiting a stable baseline fetal heart rate with no significant deceleration, and having periods of reduced variability that alternates with increased variability, in other words, a cycling pattern that defines normal neurologic behavior in the term and near-term fetus, those babies are at very low risk of intrapartum harm. Okay? Whereas if your CTG from the very set-go is abnormal, in other words, it doesn't exhibit or tick those good boxes. So even if the variability is normal, but it doesn't go through these cycles every 15 to about 40 minutes of increased variability versus reduced variability, that baby doesn't have normal neurologic behavior. And any of these adverse diagnoses are in play. And can I just make the point that there is no way you can distinguish which of these conditions produced the abnormal CTG. It's totally non-specific. All you can say is that your baby is not behaving normally. You couldn't tell whether that abnormal behavior is necessarily due to Meconium aspiration syndrome, established chorioamnionitis, intracranial hemorrhage, exposure to recreational drugs, or whatever. The CTG looks the same. The concept of tachycardia in the presence of very high rate, very high heart rate in this context has nothing to do with the definition of the abnormality of the trace. It has to do with either the baby has an ongoing injurious process, or that the insult is fairly recent. But many of these babies, if the insult has come and gone, even with a residual neurologic injury, the baseline heart rate over time comes down. So tachycardia doesn't have to be there. If you have deceleration, it just suggests that at the point of monitoring, there is reduced oxygen tension within the baby's systemic circulation. That in itself is a different matter from the prior injury. When I realized this, I went back to our own data set and looked at an 8-year period of babies that were monitored after 36 weeks, asking the question, given the way we monitor babies and the way we interpret CTG, how good are we in reducing the risk of hypoxic ischemic encephalopathy attributable to hypoxia and ischemia? So over those 8 years, we delivered just under 40,000 babies. 13.5, roughly, thousand of them were monitored using CTG and STAN, and we identified 65 neonatal encephalopathy. And this is sort of a summary of our approach to fetal heart rate monitoring and when to define an abnormal fetal heart rate pattern. And we asked the question, what is the incidence of metabolic acidosis defined as pH less than 7.05 and base excess greater than 12? So that will be here, pH less than 7.05, base excess more than 12, just one baby out of 65. Suggesting that our approach and our current target of focusing on fetal acid-base balance as a marker for risk, particularly intrapartum, to some extent is misguided. Because even when you get it right, a larger proportion of your encephalopathies will be driven by a whole range of other things. And when we went back to look at those labors, they had things to do with meconium, exposure to oxytocin, maternal fever, long labors, and all of those. undiagnosed growth restriction, and diabetes. And lastly, this is a quality improvement, each baby count quality improvement by the Royal College. And it makes the point that there's a huge overlap between some of these factors and actually adverse outcome, making the point that if we're ever going to be successful in tackling the problem of adverse outcomes, it has to be a complex approach to what is a clearly complex problem. It's not going to be one thing or the other. And I'm hoping that this group has the capability and the potential to do it. This is taken from the hypothesis, original hypothesis in the infant trial, that a substantial proportion of substandard care result from failure to correctly identify abnormal fetal heart rate. That is not true. Clinicians can tell you when the heart rate is abnormal. The same way in this large 40,000 participant study, computer told us that, look, there's a problem. It is what the clinician does next that matters more. And quite often we just either can't be bothered, or we're too tired, or we're upset by our wives and partners, or husbands and boyfriends, as the case may be. So the lesson from infant, it is not a problem of recognizing abnormality. It is failure to act appropriately, either because we don't do it on time or don't follow the guidance that we've been told to use, or we fail to interpret fetal heart rate abnormalities in the context of all the other clinical problems that are going on. So I'll leave you with these thoughts that intrapartum fetal heart rate monitoring is more than just looking at the fetal heart rate patterns. It's a lot more than that. And unfortunately, the current tools we have are so focused and narrow in its view in terms of addressing just hypoxia and ischemic patterns of injury, and ignoring the non-hypoxia pathways, including trauma, of course, which I hope Barry will be talking about. And I'm hopeful, I'm very hopeful that this community does have the wherewithal to address this problem, perhaps by use of very larger data sets and mining. So I'm afraid I've got more questions for you and very few answers, but thank you for your attention.